everybody can come in and get seated, we're going to go ahead and get started. It is my pleasure and my honor to introduce our keynote speaker. Her name is Dr. Jo Shapiro. Dr. Shapiro is an associate professor of otolaryngology, head and neck surgery at Harvard Medical School. She is principal faculty for the Center for Medical Simulation in Boston and consultant for the Massachusetts General Hospital Department of Anesthesia, Pain, and Critical Care. In 2008, she founded the Brigham and Women's Hospital Center for Professionalism and Peer Support, where she served as director for over 10 years. She continues to educate and assist organizations in developing specific programmatic and educational approaches such as peer support, well-being programs, professionalism initiatives, and conflict management. She served as chair of the Ethics and Professionalism Committee of the American Board of Medical Specialties and has held multiple educational leadership roles. It's my pleasure to introduce her to come up and be our keynote speaker. Thank you very much for being with us today.
Check my mic here. Is that good? Yeah? First of all, thank you for lasting to the end of a meeting. It's really lovely to have you here. I have to say that having been around for the last couple of days and meeting many of you and just watching your interactions, it's just such an impressive group. And I'm really honored to have been asked to deliver this keynote. I want to thank, of course, your leaders, Dr. Morris and Dr. Madden, for welcoming me. And again, for the work that you all do in the college, but also the work that you're doing taking care of all of our patients. That's the most important thing, of course. So these are my disclosures. I put up the acknowledging my own privilege and bias to remind myself always that, you know, I see the world through a certain lens, and so does each of you. And I just want to try to make sure that I'm always open to that other people may see things differently. So this is a quote from Parker Palmer. He's the person, he's an activist and educator, so he's the person on whose work my own personal professional development was based. And he talks about institutions being where the human heart either gets thwarted, welcomed, or thwarted, or broken. So what I want to talk about today are things that we can do as well, both individuals and organizations, to welcome the human heart. I think for us to have the culture that we want, we have to be willing to look at the parts of our culture that are not the way they should be. Now, I have this slide to remind myself. It's very easy to remind myself that most of the culture that we have in our profession is absolutely wonderful. I mean, for one thing, we're healers, and nobody's going to take that away from us. It's really a beautiful part of what we do. But again, if we're going to really, really establish and support a culture that we're going for, we need to look at some of the dark side. And this is, I think, a big part of the dark side, that for many years our systems have treated us as an inexhaustible resource, ignoring our physical, emotional, mental health, and we've internalized this. So I got into doing this particular work as part of my career because I had some leadership positions at Mass General and Brigham, and I just saw so much suffering, and suffering on the part of those of us taking care of patients, educating, doing research, but especially those of us in clinical care. And I thought something is really deeply wrong with this. And it was just at the very beginning of the data coming out about burnout. And I thought, this is not okay. We can't treat us as inexhaustible resources. We're not. And so what can I do as a leader to try to focus on us, essentially, so that, again, we can have sustained careers and also do the best work that we were meant to do. So look, we have acute events. You could add to any of these lists, like medical errors, just tragic patient cases, patient complaints, litigation, and then layered on top of chronic stressors like COVID, racism, harassment, disruptive behaviors, workloads, resource constraints, administrative burden, lack of autonomy, healthcare disparities. And if you think about it for a second, which I think you all have, is that this has put such an extraordinary burden on us as healthcare providers. And so, you know, this is a rhetorical question of, you know, how can we expect to sustain what the IHI calls our joy in work if we don't address these challenges to our well-being. So I want to step back because this isn't a talk on well-being overall. I mean, it's too big of a topic to have an hour of just talking about well-being, or really even the whole day. But I want to step back and I want to help us think about, okay, we have so many efforts that I'm sure you're either part of or have experienced where we're trying to improve the well-being of those of us doing the work, right? And so I wanted to kind of get my mind around, well, like, how do we categorize these? And then where does the intervention, the program that I'm going to talk to you about fit in? So let me just look at, just generally. When we first started thinking of well-being, what's the first thing you started hearing about? Resilience, right? So resilience is where we're taught to react to things in a way that's calm. We should be training for the marathon, cooking our own nutritious meals, meditating a couple times a day, don't forget yoga, and maybe throw in some volunteer work. Because these are all things that really build our resilience. Resilience, by the way, can be defined as growth through adversity. So I'm not actually making fun of any of those things, maybe the training for a marathon. Not a fan of that training. But I'm not, they're really important, but what I'm saying about them is we cannot simply put everything on our personal shoulders to improve our well-being. It can't just be up to us, right? And the other thing is people get pretty cynical when we're told that we should be doing all these things, but there's nothing about our work life that is organized in a way that would give us time to do that. So people got pretty skeptical and cynical about this. So I don't want to ever say that we shouldn't think about resilience. We should, but it can't be the only thing. So what are the other two circles? Well, one I think is a bit underappreciated, and that is the relational programs, the relational work that we do. So this, by the way, this college, having a meeting and having the activities you do is an example of relational collegial work. It pulls on that love that we have of being in community. Because I think for all of us, medicine's gotten pretty isolating to practice. And it's nobody's fault, it just is. And oftentimes you can go for a really long time without really hanging out with or talking to colleagues. And I think that's one of these reasons why a place like the college feels so good for us, because it pulls us back into a community. And these have been parts of well-being efforts that some of which have been studied, but I just want to point out you're doing it here. And then last but not least, and I think everybody will acknowledge that, the organizations and institutions that we work in, and not even just in our own clinics or hospitals, but even larger, have some responsibility for doing things that support our well-being, and I'm going to have to say, stop doing things that are draining our well-being. And I'm never about letting us as organizational leaders off the hook, because I think the hook we're supposed to be on, which is we're leaders of organizations, it is our responsibility to be looking at what are the things we are doing as an organization that we should do more of, and what are the things that we should stop doing. And I'll go off into this just very briefly, because I don't want to have the rant button pushed on me, but you can talk as much as you want about well-being efforts, but if you take an individual healthcare provider, a physician, and you make them see so many patients in a day that they're overwhelmed, the whole well-being thing goes out the window. And it's not safe for patient care. So at some point, productivity pressures just have to be lessened, whether it's the way we are paying people or what have you. So that's an example, again, of organizational responsibility. Okay, so where does peer support fit in? Well, I made the Venn diagram, so I put it right in the center where it intersects, where all the circles intersect. So peer support is clearly, and I'm going to describe the program to you, again, not as like, oh, this is the cure to well-being, because how obnoxious would that be and untrue, but just as an example of something that we can do that I think is foundational and pushes towards the culture that we want. So it's helping an individual, when there's one-on-one peer support, handle stressors, whether they're chronic or acute, okay? So it definitely is in the first circle. It is absolutely relational because it's done by a colleague, not a professional behavioral health person, but by a colleague who gets it, who's been there, who knows what it feels like. And then lastly, it should be resourced by the healthcare entity. And when things come up in peer support, in doing peer support interventions that are affecting many people, the organization should listen to that and make those changes that I was alluding to. So that's the lead up to where does this program that I'm going to talk to you fit in, because I do think we have to think of the context of it and understand, I think it's very important to do what I'm going to talk to you about, or I wouldn't have devoted so much of my time and energy to it, and especially because it's an example of something that we can and we should do. And you also might wonder, like, why are we thinking about something that's geared especially to acute rare events like errors or litigation or patient aggression, those sorts of things? And the reason is because they're going to happen to each of us. I don't care who you are. You will, at some point or another in your career, be in this acute, stressful situation. And to be left alone at those moments is unconscionable. I mean, it's the way we've done things in the past, but it should never happen. And peer support, whether it's done for, let's say, a colleague who's been involved in a medical error, it's the same principles to apply to doing peer support for any other of the stressors that I mentioned. So that's why I'm going to focus on that one acute event, but please understand it's not meant to be just for that. So here we go. We also know a lot about the emotional impact of errors on clinicians. One is we feel sad. And by the way, I won't leave you in this sad place, okay? We'll bring you up to something really, I hope this is quite optimistic for you. We feel sad, someone's suffering. Very shortly after, many of us feel a sense of shame. And shame is where you go from saying, I feel really terrible this happened, to I feel really terrible that this happened, and it happened because I am not a good enough physician. I'm not a good enough pharmacist, a good enough NP, PA, what have you. And it really is very painful. It can trigger imposter syndrome, self-doubt, and really just put people in a tailspin. I was always wondering, like, why do we feel so ashamed after a medical error? And there was a study by Helmreich that looked at the similarity between aviation and medicine and found that both stress the need for perfection and a deep perception of personal invulnerability. So what that means is we are taught in so many words that the way to keep patients free from harm is to expect perfect performance from ourselves and each other all the time. And I'm like, that'd be great. Except, newsflash, physical impossibility. You cannot eliminate human error from any enterprise. We're humans, we're wired to make errors. Wired to make errors. And so the way to keep patients safe is not going to be punishing people for making errors. In fact, it's just the opposite. It's going to be doing other things to decrease the chance of errors, but they'll never be zero. And then also see what systems factors were in place that set the person up to make it more likely they make the error, and then set the system up to prevent errors that will happen from ever reaching the patient. Very different from, I think, what many of us have internalized, which is actually, I'm supposed to not make an error, and when I do make one, it just shows that I'm not worthy. Also, our culture in our profession places such a high value on putting our heads down, getting our work done. It's like, just do your job. And I think a lot of us take tremendous pride in that, right? And also, it's not supposed to hurt. Like, everything that we experience, hey, we signed up for it, didn't we? It shouldn't hurt. Like, there's no crying in surgery, right? And the fact is, like, yeah, that's true to a degree, but never processing the things that happen to us, not sustainable. And also, we all went into this so we could fix things, and you may be in a situation where something happens that you've been part of that you can't actually fix. So fear, what are we afraid of? And just shout it out. Like, if you first realized you made a medical error, and I'm sure none of you has had extensive experience in this, but you've all had once or twice anyway, if not more, on occasion. What's a universal fear when we, oh gosh, I just made an error, and it's created harm to the patient? What are we afraid of? Anybody? Lawsuit? Yep, absolutely. A realistic fear, right? That's realistic. What else? What eventually is going to happen to the patient? Anything else we were like, oh, I'm worried about this? Yeah, what are our colleagues going to think? Our reputation? Will people still trust us? And that's a big deal because we do care, as we should, what our colleagues think of us. And I think also there are, and especially maybe less for physicians, but other healthcare providers are worried about a job consequence because people do get punished for errors. So, and then there's some anger about like, wait, I thought, oh yeah, let me ask you this. In any of your institutions, your organizations, anything, did you guys get the memo that you're done with shame and blame? Like, we're done. No, nobody sent out a memo. I don't care where you are. And yet, if you think about it, shame and blame was the only way and the major way that we acted and responded to harm events for all of these years, right? So yes, now we're moving to what's called a safety culture, which is where we look at both personal accountability and systems accountability with the eye of learning from the event. Learning from it so it doesn't happen to someone else's patient. Nothing in this about blame and punishment and those sorts of things. Now, I'm not saying that there aren't, very small percent of errors that are due to something like somebody being reckless, and that does deserve punishment, but that's not what we're talking about, right? That's just not it's just extremely rare. So, we're sort of told that now we're going on to a safety culture or just culture, but yet if you look around, you might realize that's weird because that's not how people are acting. So I'll give you some examples of that. This is a study that looked at what happens to the referrals from colleagues to women surgeons after a patient death. And the referrals dropped by 54%. But for male surgeons, when there's a patient death, very small stagnation of referrals. So people put this out there as an example of unconscious bias, which, of course it is. And I put it there just as an example of where unconsciously we as colleagues are punishing. It's a punishment to get less referrals, right? And so, and do I think that all across the board shame and blame is only towards women? No, not at all. But this is just one very specific example. So that's why I put it up there, that we have a reason to fear what our colleagues will think, and to be completely vulnerable and honest with myself and you. When I hear something went wrong and somebody made an error, my first inner reaction is like, oh my gosh, what was he thinking? But then I stop myself and I say, you know what? He's really dedicated and smart. I bet he had a good reason for choosing X, Y, or Z. Let's try to learn more about that. But we're, humans, we want to distance ourselves from things that happen. And one of the ways of doing that is to be very judgy. So again, if we're going to change any of this, we just have to notice where we're not doing it the way we want. And that's our hope always of changing. Like if you don't know you're being shame and blamey and judgy, or you don't know you're having unconscious bias, you can't possibly manage it. But if once you're aware of it, you can be like, I want to put that aside because that is no way to move through the world. And then this next slide is just a list of internal, external regulatory processes that happen, by the way, across the world, at least all the places I've had the privilege of working with. We've got M&M, root cause analysis, being reported to the Department of Public Health, Board of Registration of Medicine complaints. In the Netherlands, harm events get reported to the Inspectorate. In the UK, it's the Royal College. We've got the Court of Law, we've got the media. If you look at all these individually, you could say, except maybe for the last two, they could be done in a just culture, safety culture fashion, with the idea of learning and improvement, not of punishment, but they're often not. So again, we just have to watch where it's happening and make sure we make conscious decisions to say that's not a good way to go. Excuse me. With regard to Court of Law, just raise your hand if you've heard of these communication resolution programs, CRPs or CANDORs, anybody? I hope that within 5 or 10 years, everybody would be like, of course, that's what we do. These are programs where we have what some people call them early offer programs, but what they are is we are transparent and compassionate with patients and families after we harm them. And if we've gone through this, really rigorous process and we come out saying, you know what, actually, it's not just that we've made an error for which we will apologize, but the error, when we really look at it, is outside of the standard of care, where it really shouldn't have happened, then we offer financial restitution for patients. This has been done many organizations across the country, and we're going to be we should get out of malpractice litigation system. It's terrible. It doesn't serve anybody. It's awful for us. So anyway, there's hope on that one. But the way it is now, the litigation system is based on shame and blame. That's what it's based on. Okay. So all of these feelings can lead us to feel quite alone, right? Especially around errors, because errors, there's a culture of silence. And so isolation, because we're mammals and we're very social, causes acute and chronic stress. It's really a bad thing to have. So now I'm going to pivot very briefly to an example of a chronic stressor, which I think we have to agree COVID is now. And I've had the real privilege of giving a lot of peer support to colleagues since the pandemic started, obviously a lot before, but, and here's some of the ways I've categorized what we've been through. And again, not every one of us has been through everything, but I think these are pretty universal. We've all had some losses, right, in some way, and that loss leads to grief. And it could be grief over just the way we used to do things, or our education was truncated, or what have you. Guilt, I think, comes from we have had unreasonable expectations placed on us. And I put this out there because I think, like, being called healthcare heroes, which we were in the beginning, I think it was meant in such a lovely way, but it did, I watched it make people feel like they were supposed to reach this standard that they couldn't reach, right? Because a hero is sort of superhuman. And so I think we just have to be careful about, being expected to get way less sleep than other humans, to work in places where we're not comfortable working because we're deployed in different areas, to whatever it is. This is really a big burden if we see ourselves as it's not supposed to affect us in some way. And I think guilt comes from, I really can't meet these expectations. And then there's fear, anxiety, who hasn't experienced that, some anger about the way the country has, the healthcare disparities and how poorly I think our country handled the pandemic, to some degree, especially early on. And then anyone in here hasn't felt any gratitude over the past, year or so? I think we all have. I have to say, so I got COVID early on in March of 2020. And I got pretty sick. I was just short of having to go to the hospital, and it was like before anything, except we knew people were dying, like suddenly, just getting worse and worse. And so my husband's a pulmonologist, so he took care of me in our own little home ICU with my O2 sat monitor and everything, and I got better. And no long COVID, I wake up every morning really grateful that I didn't die, honestly. Right? And I think we all have things to be grateful for. So many beautiful things have happened, to Dr. Morris's honoring of all of you, just all the ways people stepped up, right, and helped patients and helped each other was so beautiful. So what I try to say when I'm doing peer support is, because people feel guilty for feeling grateful, is one doesn't cancel the other out. We can hold, 2 or 3 or 10 emotions at the same time. So would you not agree that everything I've said, we wouldn't want to raise a generation of clinicians that was like, meh, mistakes, systems, not my fault. COVID, beyond my control. People are going to die, it's not my fault. No, right? We should feel bad. Of course we should, because we care. So it's not about don't feel these things. And many times we do recover without even anything. It can, time does heal to some degree, but the problem is not in all cases. And sometimes recovery is truly thwarted, and this can be pretty devastating. And there's lots of things I could have thrown up here data-wise, but I'll just put up a couple to show you. So this is just a study, it happens to be a physician study, on the long-standing sometimes effects that being involved in a medical error causes. And if you can see this, if you look at the blue graphs, they're for when it was a near miss and the error didn't even reach the patient, and there's still negative fallout. I mean, it's really devastating, right? These things are really draining and awful. And then it gets worse, of course, if there's been significant harm, but not zero, even if we know the patient didn't come to harm. This is a study I was involved in where we looked at nurses and physicians when I was at the Brigham, compared to nurses and physicians at a hospital in the UK. No difference, by the way, between any of the 4 groups. And almost a third had some really lasting negative impact on their work performance or personal life or colleague relationships. The data is pretty clear that burnout and depression are independent predictors of having made a recent major medical error. That's problematic. And we know it's almost like a cycle that if you've made an error, you have a higher chance of being burnt out. If you're burnt out for whatever reason, you have a higher chance of making a medical error. So, we've got to interrupt this cycle. And then very disturbingly, having made a medical error is a risk factor for suicidal ideation in physicians. And it says MDs, but I'm not sure, who all was surveyed, but that's just bad and scary. And risk factor errors are a risk factor for completed suicide in physicians. It is. It's not the only one. I'm not here to say that that's the only problem, but it's one we know about. So we wanted to know, okay, how do you actually facilitate resilience? How do we get people through, not around, but through these stressors that we're all going to experience? And so we did a study, and we looked at lots of different stressors and how often people experience them. And it was pretty impressive that, within a year, like almost 80% had experienced either a significant personal stressor or a significant work stressor. When we asked specifically if you were involved in a medical error as a stressor, where would you want to get support? 88% wanted to get support from a physician colleague. That's pretty high, right? Even though we had great mental health professionals, employee assistance program, a really good one, most people want to talk to someone who's been there, who gets it, who knows about it. This was another study that looked at what facilitated wisdom and resilience after errors. It was also physicians. And one of the factors was talking about it with colleagues. So you need to build a program based on the data that shows what do people really want, what do we want? And this is what we want. We want to talk to a peer. So we decided to build a peer support program, and it's the one in the middle, the formal peer support. So I bet every one of you has either received and or given some informal support. You check in with a colleague, how's it going, what's happening, which is a really important thing to do. The problem with it is that's not going to be enough for everybody. Some people it will be, but it may not be. And you're not, like if you Lindsay, you run into me in the hall or at a meeting and you go, hey, how's it going? I heard things were pretty stressful. I'm not expecting you to sit down for 45 minutes or an hour with me so I can really unpack the fact that I'm not sleeping, I'm not sure I should keep doing this work, I feel devastated, right? It's sort of a check-in, right? As opposed to like a real sitting down in a way that can help me unpack this. And the other thing is, it turns out sometimes inadvertently when we do informal peer support, we try, because we don't want our colleague to feel pain, we try to minimize their pain and say, hey, that's not your fault. You shouldn't feel bad about that. But the problem is minimizing people's pain just doesn't work. It just makes them feel bad about having the emotion. So formal peer support, again, informal would be enough for many people, but not everyone. Formal peer support which is what we train for in our programs, is where not behavioral health frontline clinicians are trained to sit with a colleague, either virtually or in person, but more and more virtually, and help them move through and strategize so that they can begin a journey of healing. Right? It's not to fix them. It's not to take the pain away. That if we could, I'd sign up to do that. It's to help people find a way forward. And so we have to train out certain aspects of the work that we normally do, which is like my first reaction, somebody brings me a problem, I take it on, I want to fix it for them. And I think anyone who's a parent in here knows, like sometimes you try to do that with your kids and they're like, I wasn't asking you, Mom, to solve it, I just wanted to tell you about it. Okay, what a novel concept. It's the same thing here. We all want to fix. Like, I think that's pretty universal, but this is not a fix it, but we can do things to help people, even in addition to empathic listening. So those are things that we train for. That will be wonderful, but maybe not enough for everybody. Some people are going to need, want, and deserve further resources. Behavioral health people, coaches, people can do, this is, because formal peer support is a one-off, it's emotional first aid. But some people need more, and the problem with us is that we are really, I'm gonna say, reluctant to seek professional help for lots of good reasons. And so our job as peer supporters, trained peer supporters, is to both destigmatize and then facilitate referrals for more longitudinal professional support if the person wants them. Never to force anybody to do any of this. This is all completely voluntary. Okay, so this principles of peer support are basically when I train, it's like the most important thing to remember, it's your loving presence. It is not about I'm showing up here, to do this way. It's like I'm here for you. And then to listen in a very kind of specific way, to use non-judgmental curiosity and questions, reflective prompts. Has this affected your sleep? Have you found you're ruminating about this? Those kinds of things. And then problem-solving guidance. Instead of my saying, oh, this is how you should approach it, it would be more like, is there someone you're worried about an M&M coming up? Are you worried? Okay, is there someone in your group you trust to talk to about this? That sort of problem-solving guidance. And then explore their own coping mechanisms. Hey, what do you do in times of stress? Or just even, what's your self-care practice? And then encourage people to reconnect with that. Versus my saying, well, I found, doing meditation really, really works for me. It's like, well, good for you, but you're not me. So you want to bring out somebody else's coping mechanisms. And then helping them put this stressor in a context of who they are, that they don't feel like it's the only thing that they are. And then connecting them to resources, and there's a specific way to do that destigmatizes it, if they want to, and then appreciating that. So operationalizing peer support or any of these programs is not easy. And we learned the hard way meaning we tried one way and it didn't work. And so, okay, I'm here to tell you, don't do it the way we did it initially. So we initially had it as a reach-in program. That is, I trained, a good 50 frontline clinicians at our hospital to be peer supporters. Somebody throw out a guess of how many peers reached in and said, hey, I need help, please help me. How many do you think we got? 0. I said I felt like we were all dressed up for a party and nobody showed up. But we're here to help. So we're like, this isn't working. So we're gonna add a reach out component, which felt very countercultural. You're gonna reach out to somebody and they haven't asked for help. Aren't they gonna think it's like an invasion of privacy or they're being identified as weak? And when we do the training, we script and help people do the reach out in a way that normalizes it and makes it very voluntary, but also like, hey, we reach out to anybody involved in X, Y, or Z. That's what we do. And I've been there, and some of us find it helpful to talk to a colleague because that's something you'd like to do. So this is a quote from a colleague and with whom I wrote an article in the New England Journal about doing emotional support for clinicians during COVID and beyond. We wanted to title it, If You Build It, They Won't Come, but New England Journal doesn't think those kinds of things are funny, so we didn't even put that in as an option. But it's a quote from him because that's been the problem with many support programs and mental health programs is like they're so poorly utilized, especially by physicians. They just are, because of all these barriers. So you have to build the program understanding what those barriers are. So you do not have these peers who are already suffering have to climb over these big barriers. So this actually was part of our study. We asked what would the barriers be to seeking support? Lack of time, stigma, lack of confidentiality, access, et cetera. So you make it easy and destigmatize it. This is my concept of some of the cultural barriers that we have that prevent us from saying, I'm hurting, let me get some help. And the last one, is this idea that somehow self-care is selfish. Isn't it incredibly ironic that we're healthcare providers and somehow caring for ourselves is just has never been on the radar? Now it is more recently. I'm hoping this doesn't sound like, it's just the same way it was. But it's still not really accepted. And now I'm going to veer, and I'm going to tell you a story. Okay. In November, my sister and my husband and my brother-in-law and I all drove to, we live in Boston, we drove to New York, to Manhattan, to visit my aunt, who is an amazing person and a very active world traveler, but we hadn't been there to visit her since COVID. And we had an amazing time. She took us to a Broadway play. She insisted, as she always does, that we take the subway and, lots of stairs up and down. And this theater on Broadway, the stairs to the, where we were sitting were like, like climbing a mountain. And she's, in her 90s, but it fit as anything, we had to keep up with her, let me put it that way, walking, okay? And we walked, lots and lots of places in Manhattan. Great time. And my husband and I slept overnight. The following night. And in the morning, we woke up and she comes out of her bedroom and she said, something terrible is happening. And she dies, literally, in front of our eyes. My husband's, as I said, pulmonologist. He can run a code like nobody else. We tried to get her, we did everything you could. We got the EMTs and, everybody tried everything, took her to the hospital. She died. Why am I telling you this? Okay, first of all, I want to say, it was the best death. If I could sign up for that death, that's what I would do, because she did not suffer. We were right, which is she had 10 seconds of something bad is happening, and then she was gone. And it was in front of us, right? And for us too, we were there with her. Think about the probability. I mean, it was amazing, right? So, but it was still, doing CPR on your, 90 whatever year old aunt was not fun, for sure. I mean, and she was so healthy that it was shocking, that she was dead. It was like, oh my gosh, she's dead. Okay, so then we was staying in town. We were going to bury her the day after. But the immediate day after her death, we of course, was staying in. Had planned on going home, and I was planning on doing a Zoom peer support training for University of California at Irvine. And so that next day after she died. And so I was like, I can't cancel that. I just can't. I mean, these people are, I'm going to train them. I'm doing grand rounds. I can't cancel. So I did it. I told Dina McRae, who is the GME director for UCI, look, this happened, but I'm going to tell you, I'm only telling you because the Zoom connection is pretty, I don't know how good it is in my aunt's apartment, but I wasn't planning on being here, but this is why I'm here, and we're going to bury her tomorrow. And she said, don't you want to cancel? And I was like, nope, I'm committed. I'm going to go forward. So I did. And then the following day, the day of her burial, I was supposed to do a second peer support training, and Dina texts me, and she goes, Joe, I know you're a grown-up, and you make your own decisions, but I'm just wondering, are you sure you don't want to cancel this next one? And I was like, I surely do want to cancel. Because I just didn't realize, I'm an expert in this, right? But self-care for me? No, that's for all of you. I just didn't even give myself permission to cancel after my aunt died in front of us. But it showed me, and Dina and I laughed about it. She happens to be a psychiatrist, and we were like, I said, this is a little bit hypocritical for me to power through this when I'm telling everybody, don't do that stuff. That's crazy. But it just reminded me of how ingrained all of this cultural expectation we have of ourselves, and how, again, I'm supposed to be an expert in this, and I too felt like my first obligation was to all these other people, versus, yes, it is, and for me to show up present and really available, I need to take care of myself. I mean, and this would have been a raise. So, plus I was telling my sister, you have to cancel, she's a psychologist, you cancel all your patients, and everybody else should cancel, but not I. So, long story, but think about that. That's how much we internalize this. I don't need help. Self-care and self-compassion are selfish. So don't do that. Okay. So I believe, as I tried to argue, that we shouldn't be putting on the burden on individuals to reach out for help. And by the way, if you think of what enabled me to cancel, it was Dina reaching out to me saying, giving me another chance. Are you sure? And it was giving me permission. And I think we need permission. permission to think about how we're doing because we don't have it internally because of our enculturation. So, and let's not offer peer support just when we see colleagues are stressed, even though it's proactive, right? Because let's just know that after errors, for example, or significant, patient aggression or just horrible things that we see, like we see sad things, don't we, right? It has nothing to do with bad care or good care, whatever. And, okay, yeah, in the moment and during a code or whatever, no, then we have to be thinking of other people, but forever, no, we should, after stressful things, we should be offered support because we're human. And then I think integrating into our interactions every day. I think anyone named in a lawsuit should be given proactively an outreach by somebody who's been there. To leave someone alone at that point is crazy, I think. These are the communication resolution programs I was talking about. So all of these programs, they have, they strongly suggest a peer support program, obviously a patient support program, and a whole different way of handling harm events. So lots of things, if this interests you or whatever, you could think about, it doesn't have to be errors only. It could be any of these things and any chronic stressors that your peers are feeling. So I'm going to close in just a minute or so. But before I do, I just want to invite you to think of a time when you were at work and you were working really hard, right? You were really just in it. And you were focused on patients, and it was just going. It was like flow. You were really working hard, and everyone around you was supporting you and each other in taking care of this patient, whether it was a small team, whether it was a bigger team, whether it was administration, whatever. You felt like you were supported in doing the work that you want to do, which was taking care of patients. We've all been there, right? Just experience for a minute how great it feels, even when the work is challenging, how great it feels to have that sense of support and trust and respect from everybody around, okay? That, I think, is where we should be going for. And, peer support is a kind of program that I think helps because it helps us see that the way we normally interact or in these acute stressful events is, not that. But also I want you to envision things that you can do to create and support that sense of mutual trust and respect throughout your teams, because that is going to improve our well-being. And one of the things that's helped me do that is, let me just give you this definition. So to have that kind of, teamwork and that kind of sense of support, you have to have what Amy Edmondson, and she didn't define it, but she's popularized it because she researched it in medicine. Team psychological safety, which is a shared belief in interpersonal safety within the team. And you can define team for you as any way you want. But the sense of confidence that the team will not embarrass, reject, or punish someone for speaking up or for suggesting something that's wrong. And it stems from mutual respect and trust among team members. Mutual respect and trust, which is a beautiful thing, right? It doesn't just happen, though. It has to be created and maintained, especially by you as leaders, often the team leaders. So, let's see. For me, one of the things that's been most helpful in dealing with either failures, whether it's of the patient care, I wanted to have it come out one way, it came out another way, or just in my leadership or in an interpersonal interaction, is to say, I am going to use this as an opportunity to grow, to learn and to grow. It doesn't feel good right now, and that's okay, but I am going to think always of how can I be better? And somebody once called this just think of how you could be 1% better. Just 1% better every day. What could I do to be 1% better? Including what am I doing now that I want to do, that's good, that I want to do more of. It's not all about where am I a big mess up? And I just feel like this growth mindset, which I think if you think about something like the college, right? You're here, a big part of why you're here, in addition to pulling yourself as a community together. You're here to learn. That's so cool. Like, that's why we show up. We love to learn. I mean, learning is like, it's so fun. And so to the extent that we can think of our experiences, even difficult ones in our work and personal environment too, as, okay, this is hard, but let me use it as an opportunity to grow. That has been very helpful to me just in my life, and not something I would say came easily, because I just always wanted to, get the A, okay? And that's really not a great goal. Like, learning to grow is more important. So back to peer support itself as a program. I think it's a culture change driver. It takes us away from shame and blame and towards a just culture or safety culture. It goes away from saying we're supposed to be perfect to, hey, human factors, which is the science of safety, says that none of us is perfect. That's a physical impossibility. It goes from saying, you signed up for this, it shouldn't hurt, to it hurts because you're caring and compassionate. From this sense of I'm alone and I'm just the only one this has happened to, or nobody else seems to be talking about these things, to the fact that no, you're in community, and it's represented with the peer support program by a specific peer, but we're standing in for the community. And then, of course, moving away from, I think I've hit this hard enough, self-care is selfish, to actually, it gets us back to doing what we do well, and plus we deserve it because we're worthy humans too. So, if you notice, I don't use the term second victim, and the reason I don't, even though I thought it was a brilliant term to start with, I really think it was very important. I don't use it anymore because the patient advocates I work with do not like our referring to ourselves as victims when we've inadvertently harmed them. They just don't, it doesn't sit well with them, so I stopped using it. Also, I think victimhood has a very, lack of agency, and this is a quote having nothing to do with medical error, but from Parker Palmer, talking about that we're not victims of our world, we're its co-creators, which he sees, and I think you would agree, as a source of awesome responsibility and profound hope for change. So just put it out there. This is a tweet that I read, and I thought, oh my gosh, this is us. I dream of never being called resilient again in my life. I'm exhausted by strength. I want support. I want softness. I want ease. I want to be amongst kin, not patted on the back for how well I take a hit or for how many. Instead of hearing, you are one of the most resilient people I know, I want to hear, you are so loved. You are so cared for. You are genuinely covered. And I thought, that's who we are, really. This is what we're all doing together. So I'm going to stop, and I'm going to thank you for being here and present, but also more especially for all the work that you do, and also for inviting me, because it's really just been an honor to be here. So thank you so much, and love to hear your, not just questions are great, but also what do you think? What do you feel right now? Where are you like, Joe, seriously, no? Or yes, that's, of course, that I like that part of it. Whatever you're thinking, feeling, I'm interested in hearing. So thank you so much for your presence.
I will tell you what I'm thinking right now. And what I'm thinking is that was awesome. I think that we all have had those experiences. And I think, again, whenever something untoward happens, the blame comes so much to us, we blame ourselves so much. And we expect ourselves to be perfect. Yeah. And, unfortunately, no one is perfect. Yeah. But it's hard to remember that lesson when that's happening. And so I think that was just an awesome talk. So that's what I'm thinking right now.
Thank you. I really appreciate that. Really, like I said, anything you're thinking or feeling, I'm interested in hearing. I mean, and I was talking to somebody last night. One of the principles that I've learned in my professional development is hold the outcome lightly. So in other words, when I prepare for something like this, like all I can do is be the best person I can be prepared, be ready, have learned as much about you and what you all would want to hear as possible, and then deliver as best I can. But how it sits with you, I have no control over, so it's all really rewarding that it did sit well. So that's very helpful to me, so thank you. Anyone, any reactions? Any part of it that either resonated or didn't, or you're worried about, or made you think of something? Oh, yes. Yep.
You have a colleague who has a significant malpractice, and you suspect that colleague's having significant impact. I'm not a trained psychologist, I'm not trained in counseling or whatever, although I took a lot of psych in college 50 years ago.
It counts.
Is it appropriate for me to step forward and go to that individual and say, hey, I'm a colleague, how can I help? Or is that inappropriate?
I think it is highly appropriate and lovely and warm and caring, and I think it should be done. If I could just sort of add to that, like if that's what you did and you just said that, that's enough. But let me just add a couple things you might be able to do in addition to that, like as you do that is, for one, sometimes the question is how can I help? It just, people don't know. So one maybe just, an alternative way of saying that is just to say, I know, I mean, people are always like, well, how do they know that I know it happened? But in most settings, I don't even care how big your organization is, everybody around you knows what happened, right? So you would have reason to say, hey, I know this happened, or what have you, and you're alluding to that, is to say, I've been there, and I think sometimes it's helpful to talk to a colleague. Is that something you'd like to do? I'd be happy to sit with you for a bit. If you don't want to do that, that's cool too, but that's maybe just the next step up, if you will. And then not to be worried about what the person says. So two things. One is if someone says, I'm good, I got this, or no thank you, you have still done an intervention. They know you care. They know it's not so horrible. And they know you've been there. Right? So you've normalized the fact that like these things happen. You haven't assumed that they feel any way, you don't want to say like, I know just how you feel, which you didn't, because no, you don't. You know how you felt when you put, but you're saying, I've been there, and that's very normalizing, especially if you're more senior and you're talking to a more junior person, they're like, really? Because we're so quiet about this, it's so crazy. And so I think, so you've already done intervention, and they could say, no, I'm good, but they know. And then you could leave it that with, of course, that's fine. If for whatever reason it would be helpful to just, to talk, or anytime, just give me a call anytime, I'm here for you. Okay. Or if they say yes, I wouldn't worry about what if they say this or that or the other thing, because, and this is one of the things I train, but I'm gonna tell you right now, is you're not presenting as their doctor, or their therapist, or their coach. You are there as a colleague. And so if someone then sits with you and says, I'm feeling, like, I don't know if I can continue, what you can respond to is, well, I want you to feel, I want things to be okay, and I don't want anything bad to happen to you. I wonder if there's someone I could connect you with, or that that you could talk to get some support. These are very stressful moments, so that you're sort of helping them get further help. Because a lot of times people are afraid of asking somebody, because what if they say this, or what if they say I'm suicidal? It's like, then you say, can I get you help? You're not responsible for taking care of them, whatever they say. So I've seen, I had heard this great lecture from, she's a pediatrician. She's at Mass General, and she was doing grand rounds, and she had suffered from significant depression, like she was suicidal. And she said it was so obvious that she was disheveled, she wasn't concentrating, and literally over the course of, it was over a month, only one colleague asked her how she was doing, and she said fine, and the person never came back and said anything. So ask. Is there, and you said, can I help you? That's fine. Now that I think I don't want to tell you what to say, because I don't think there's any harm in saying that, but just saying, I just want you to know I'm here for you. Or do you, I'm going to go back and say what I said was wrong. Is there anything I can do to help? I think that's fine. Good instincts. So yeah, beautiful, lovely, do it.
Thank you so much for your wonderful talk. I don't think it's coincidence that this topic is brought up. COVID's been very hard for everybody. I think there's more awareness about mindfulness, self-compassion, empathy. This only came about in the last 2 years for me. I wish it was around much earlier in my training. It would have been much helpful during internship, residency, all the hard times. I always just thought it was me going through those hard times, didn't know how to get through it. I would keep going through the same thing, even with like patients, parents, the way they talk to me. I would take it personal, then I would talk to friends, colleagues, and say, how do I deal with this? So really learning about this, being mindful, being self-compassionate, it's okay, you know, we're human. There's probably something else going on with them that's totally unrelated, and they're just dishing it out on you, you know, things like that. So I think this is very helpful, and I think it would be great to set up a program where we can start early, maybe even during medical school years, bringing it out. Yeah.
Thank you, and I think I appreciate your sharing. One of the things that, you know, as I've moved along in my career that I've seen so brilliantly done by other people, and I've tried to emulate that, is that vulnerability, which you have just expressed, is courage. It is not weakness, it's the opposite. Like, people can stand up and say, this hurt, this happened, or this is happening and it hurts, are the most courageous people, so thank you. Yeah. And I think, so you made two other points that I just want to, or you made 2 points that I want to land on for a second. One is that I think the way patients treat us it's gotten more challenging. You know, I think we could all agree with that. And it hurts us, you know, and just being saying, oh, don't take it personally, but help us process that, because it does hurt. And so it's sharing that and having other people say, oh my gosh, I know that happened to me, or that happens to me, and here's what I do, or, you know, what makes you feel better, those sorts of things. So that's one thing. And then the second is, I do think this, I mean, all of my programmatic work has been my decision was, let's start at the level of faculty. Because we can teach med students one thing, but when they walk in our clinics, you know, in our health, and they see us doing the opposite, that's what they learn. And so I said, we've got to start with us, right? And I think it should also be like they're prepared for, like, oh, this is the culture that we're moving towards. Also, students could be prepared for, but we're not there yet. So you might see isolation, you might see shame and blame or denial or what have you. Know that that's not cool, but we're moving towards this other thing. So I think the idea of, like, let's just get this integrated, this is what we do for each other. And the last thing I wanted to say is, if there's one phrase that I hope like everybody can sort of have as a mantra is, you're not alone. You are never alone. There are always people who are there for you, always. In our lives, especially in medicine. We have beautiful community. It's just, it's not part of our culture to access it. So, thank you. Somebody right there? Oh,
sorry, I'll bring you.
Oh, I'm so sorry, okay.
I'll bring you the mic after.
Thank you, Dr. Shapiro. I really appreciated your talk. And I thank you for your honesty, because oftentimes it's hard to say we tried to implement this and it failed. And I think from a system standpoint, we've all sat through grand rounds where it's more as we checked a box and we have this hotline and reach out to us if you need us. But I completely agree with you. I haven't researched it, but the generalization is that our numbers are very low of the people being proactive and reaching out to us. And I do think that we can learn, and as a system, we need to be more proactive and reach out to the people in need. Can you provide more feedback since the modification of how successful the program's been, and what have you learned from your second phase for potential future modifications?
Well, thank you for the question, you know, and the insight. It was very easy to get better because we went from 0 to more than 0. It was a low bar that we started with. It was a complete change around, and we did it pretty quickly. I mean, maybe we waited 6 months, and with absolutely nothing, we're like, this isn't working. What we had to get over was this idea of, like, how can we how can we feel comfortable doing the reach out because we were so worried about how people would react. So one of the things I want to answer to you is that I literally have never heard anybody react poorly to the offer for the reach out, which is shocking. So it really is. Like, all of our fears of what people, like, why are you calling? And, there's nothing wrong with me, or how'd you find out about this? And I think part of it is the fact that people appreciate the fact that there's a program, and also the way we're training people to make the reach out, it's very normalizing. It's very much like, hey, this is what we do. And so, and especially as you build the program, people get to know it more. In the beginning, it's still a cold call, because even if you do a big program announcement, anyone delete emails ever with announcements? Yeah, right? We all do. So people still might not know about it, but you say, I don't know if you know this, but we have a program here and we reach out to anybody. Or in your case, if there's no formal program, you can say, look, I think we should be reaching out to people because I've been there and that would have been helpful to me, or that's somebody did this for me. So you can normalize your reach out even if you don't have a formal program. But what's really interesting to me is that it tends to be very well received, even when someone says, I'm good, thank you anyway. And the other thing that we added, which I think was really important, this is very hard to study, by the way. I am trying to study it, but for lots of reasons, it's really hard to do outcomes research for a program like this. So I'm going to tell you more from experience, which is that it's really good to have a list of further resources at your fingertips when you're reaching out. Or even if it's not in a formal program, just to be able to say to somebody, I know we have, here, the people in the community that you could reach out to if you need this, or, whether it's like physician health services or, a psychiatrist that or a psychologist, whatever, just so you have, or EAP, whatever you know about. And so we just made that as part of the routine, is even if someone said, no, thanks, we would say, is it okay? Nope, that's fine, totally fine. Is it okay if we send you an information sheet on further resources, just in case for whatever reason down the line, or you or any of your colleagues might want support. So then you've sort of spread the word of hey, it's okay if people want further resources. So that was sort of an addition that I think was really helpful. I think I'm going to leave it, maybe it's on a negative note, but to your point, it's better to be honest about it. I think the problem with the programs that I've helped initiate and maintain with others is there are so many people out there who are probably suffering that we just don't know about. We just don't know. Now, if you're in a very small group and everybody knows it, that's less of a problem, but if a bigger organization. And so I think, the challenge is making this, integrating this into, for example, at the end of a clinic where there's been a difficult event, is making sure you gather the people around you and say, the MAs and the, whatever, and say, I just want to spend a moment here to say, that was hard for all of us, or just and acknowledge sometimes these things affect us, and if people are suffering from this, I'm going to be processing it, but I just want you to encourage you to get some support, and here are some ways you could do it. So sort of normalizing it within our own clinical day-to-day lives, and that doesn't mean you have to have a meeting every day. But what about at the end of the week, just where you say, hey, here's some things that went really beautifully. Here's some things I think were traumatic or difficult, or just, hey, we could do improvement. That sort of routine gathering of people, because we're so busy, right? We're just work and then we run. We work and then we leave. Work and leave, but we don't gather. And I'm talking 5 minutes just to say, hey, this happened, or hey, that, and you could even say, that work today, which was particularly challenging for the people who were rooming that patient, I really appreciate that, So that's another thing, is sort of integrating this. Thank you. Yes, and somebody here.
And I thank you, too, for your beautiful presentation, Dr. Shapiro. There's a book that came out recently. It's called Self-Compassion by Kristen Neff. And I don't know if you can comment, or have you read that, or are there other resources out there?
There's a bunch of resources, but tell me, have you read that?
Yes.
Tell us a highlight or anything, because
Well,
I haven't, I'd love to.
I just think the big message that came out was being kind to yourself, and we're so critical on self-criticism of self, really defeats a lot of us.
It does.
And I think, kind of the point you brought up, we've got to find our own self-compassion.
Yeah.
So.
And there's something about a peer giving you permission to be compassionate. It's really, because one of the things we do is reframing in peer support, and it's helping people see that this event, this thing, is not all of who they are. It's a bad thing that happened, and they wish it hadn't, but they're not this thing. They are all the other amazing things they've done. And so it's giving each other permission to do that. But thank you. That's a great. I will be reading that. I appreciate it.
Thanks, Dr. Shapiro, for your championing this issue. You asked us what was our impression or our reaction.
Yeah.
And I wanted to just mention, in my own experience, I went from I was in the military and retired about 4 years ago. And I went from a system where we had a healthcare resolution specialist to help with, and stopped using the moniker of victim, but helping the physicians or healthcare providers of any kind that had gone through difficult situations like this. We even had in our institution, in our hospital, an actual mental health care specialist who was helping with the providers who could actually, they could go to this person. And then I retired and went to a private group and a private organization, and then in our state in California, most of the hospitals don't have the physicians as employees, to an absolute desert of support in any way, shape, or form. And so from the hospitals that we're actually medical staff at, I don't really hear much from them in this sense. And I was wondering from you how you've rolled. It seems to me that the private institutions have not embraced this as much as some of the more public institutions and the larger groups. And I'm wondering, have you made any inroads into how to bring that to the private institutions, the private hospital systems in the different states and with their different laws and employment practices? And if you haven't, how do you envision that going forward?
Yeah, thanks for your observations and your questions. So I have had, I've worked with all shapes and sizes of programs, private practices, hospital-based, ambulatory-based, academic medical centers, many states in the U.S., several countries outside the U.S. So, and it strikes me when I'm doing program building, program development, I always ask very similar questions, but they're going to be different answers depending on, which particular organization I'm working with. And it's things like, what do you have now that's working? And, to your point, an organization might say pretty much nothing. Others say, well, we have EAP, but nobody, physicians aren't using it so much. Or, no, we have a great X, Y, or Z, and they're, okay, great, so maybe, do we really need this? So, that's sort of things. And who in the organization finds out when stressful things are happening? Are they bought into the idea of having this program? Because you have to have people who tell the peer supporters, hey, this is somebody, you should reach out to, unless it's so small that everybody would know anyway, and you have that defined. But what I would say is, I see absolutely no principal differences except for, the kind of like, logistical, who's the head of it, who to contact, but the principles of it are exactly the same everywhere I've been, and it's been, over 100 organizations. And so I don't see any major differences, except, there are, but they're just structural, operational. They're not like principle. It's very transferable. It doesn't matter the size of the organization. It doesn't matter whether the people are employed or unemployed, not employed, independent. It's the same. Like, who are you going to provide this for? Who's going to resource it? Those sorts of things. And they would be a different answer, but it's still the same. It's still, you need some kind of reach out. You need some kind of list of further resources. You need some kind of buy-in. If you're going to do it for errors, you need some buy-in for whoever does legal. If you have anybody who you would be, that sort of thing. And if anybody's worried about the legal, I could talk to you offline, but there's we made the argument that even Massachusetts, where these conversations are not peer protected, they should be, of course, it's ridiculous, but we were like, we're going to do it anyway. And this was in consultation with our our in-house legal, our risk managers, our risk insurers, our defense attorneys and all that. We're going to do this anyway. And so we don't take notes, and it's never brought anybody harm. Anyway, I can tell you more about that, but the point is, it doesn't matter the laws of the state, you can still do this. So I hope that answers, but I'm sorry. I also want to say, that's awful. Like, it's awful to see the absence of this, because I think, honestly, I really think irrespective of whether it's this program or whatever anybody wants to do, I think we're going to look back and go, can you believe we didn't ever reach out to anybody after stressful events? Oh no, is that true? That's what it should be like. It should be like, of course we do this. And it doesn't have to look like this. It can look like a variant or what have you, but it just should be part of what we do. To your point, in which you're, just do it, right? And then with training, I can help you do it better, maybe, just build on it. But without that, that's fine too. Do it, do it, do it. Keep at it. Thank you for raising that, because some places have nothing. It's terrible.
Dr. Shapiro, we have one last question.
Okay.
Hi, Dr.
yeah.
Shapiro. Thank you for coming. This is enlightening. I've spent all of my career.
Didn't you win an award last night?
No,
Oh, okay.
I don't get awards.
Okay, sorry. I thought it was you. Go ahead.
I'm in the middle of the bell curve.
Oh, okay. It's a good place to be.
I've been in practice in a small town, a small hospital for 34 years, and I've done all levels of medical staff and all those type of decisions. And I watched my hospital go from a small community hospital into a much larger hospital. But what's also happened is the advancement of the bureaucracy to protect the hospital. It's not to protect the physician, it's to protect the hospital. So now when something happens, it goes to risk management, and then it goes through quality. And it's taken completely out of the physician's hands. And in my perspective, and hopefully everybody else's perspective, is that we're all harder on ourselves than anybody else is ever going to be. And it doesn't matter whether you're fixing a lawnmower or you're doing surgery. And the fact that it's taken out of your hands with committees of people that but it's in a committee and it's being discussed in another committee, then you're going to come back to a surgery committee, and then we're going to go over what happened, is that nobody really wants to talk to you about it because we're in committees, and it's all protected.
Yep.
And we don't know if we can. And I think the corporate environment has made it so we're basically cast off. That even if we talk to each other as colleagues, that it's still, you're going to break protected speech or whatever it is. So you bring up some very, very valid points, but we're still fighting. I think in some ways the corporation is trying to protect itself first and not us.
So I thank you for bringing that up, and I think that is a challenge. I'm going to say, so I obviously had to meet that challenge depending on which organization I'm working with. So I think that I have two observations. One is what you described to me as far as what happens to the discussion over the event could be and should be changed. So I have a remedy for that, okay? Forgetting peer support for a second. I think that at any time there's a significant event, there should be a group of people that sits down and answers the following questions. Knowing what we know now, is there anything we would do differently? Knowing what we know now, are there things that we did well that we'd like to repeat? Knowing what we know now, it's all retrospective, knowing what we know now, is any of those things we think we would like to do differently next time, would we consider them an error, in which case we need to apologize? And then the other question shouldn't be in that group. It should eventually be, okay, and is this something that needs to be reported? There's all sorts of other stuff that has to be, shouldn't be the people doing the event analysis. So I think one of the huge, and I was very involved in, I'm a patient safety person, very involved when I was at the Brigham. I sat on the patient safety executive committee, et cetera, involved in doing these analyses, and I was the disclosure coach for the whole hospital for years, where I prepared anybody who's going to have talked to a patient where they were uncomfortable with it or it wasn't clear what happened. So I have a lot of experience in that world, and I think the way we do that, you know, especially when it's committee organized, it's like it's got to be incredible opportunity for everybody, including the involved healthcare team members, but let's say specifically physicians, to put into that group of like, here's what I've learned from that, and then if, being given the opportunity to share that knowledge with others. So that should be completely redone, I really believe, and it's not hard to do. But the other question you have is like, but are you being prevented from being collegial and just talking? Because you are told, we're all told, and this is still true, and there's good reason. If you know anybody talks to risk management is going to say, don't talk to anybody about this. Why? Because what they're worried about is fair, and it's not just to protect the hospital, it's to protect you too, is if this becomes a lawsuit, the plaintiff's attorney will say, did you talk to anybody? And what they're looking for is you talk to a colleague, and then they can subpoena that colleague, and the colleague can testify against you. Yeah, I told her she shouldn't have done that surgical approach or what have you. That's what they're worried about, okay? So we had to deal with that, like, oh my gosh, these are not protected conversations. They're not going to be protected in Massachusetts. Some states have put them under things, but many times they're just not. So we're like, but we're going to do it anyway. Why? Because the risk of causing harm to that peer is present but tiny. The risk to causing harm to that peer is huge because of all the data we have of unsupported physicians, for example. So we decided together, and this was risk management and everybody else, we're going to do this anyway. We don't take notes. So even if I peer support you and then you're involved in a lawsuit, first of all, I may not even be, you know, in your institution. I may not even be in your specialty, right? I'm not, and even if I am, when I talk to you as a peer supporter, we're not saying like you should or shouldn't. I'm not analyzing the event because that's not what we're just supporting you, right? So I'll hear about the event. Sure, I know about the event or I've heard about it or you're going to tell me in peer support, but there's nothing they could ask me that would harm you. So our defense attorneys were like, bring it on. We're not worried about it at all. But we thought about it, and again, no notes, it's all de-identified, et cetera. So I think, I am like I am a big organizational change proponent. It's like, do not tell me we can't do this. We all know this is the right thing to do. It's what's wanted. We have the data for that. We have the data for not doing it. Come on, people. Let's do the right thing. Is there a tiny risk? Sure, but let's do it because there's a bigger risk if we don't. So that's how I've helped people argue to do it. And I would just say, like, you just do it. You know, I don't know your name, but you say you're going to ask a colleague, you know, just offer to help them. You're not going to sit there and judge what they did and those sorts of things. That's not what you're doing, right? And so it's a different hat. So I guess that's how I'd answer it. And I have to be a bit patient because you have to work with bureaucracy to get these things through, but it's like, we'll do this. Tons of places have done it. No harm has come to anybody.
So, Dr. Shapiro, I want to thank you again. That was just an awesome talk. And it was fun for me sitting up here watching you. There's just such a joy in you when you're speaking, and it's fantastic to watch.